Hello, today we are going to go over genitourinary abnormalities in the obstetric patient. So we're going to start out by talking about the embryologic process of the urinary tract development, and we will review normal ultrasound findings of the kidneys and bladder, as well as genitals. And then we'll talk about Potter's classification of those congenital renal cystic diseases, describe obstructive renal anomalies, and those two things should be pretty familiar from your abdominal class. And then we'll talk about various renal malformations that can arise in utero, and then discuss genital anomalies as well. So starting off with embryology, in the 7th week, the uretic buds and metanephric mesoderm develop. This develops into the uterus, the renal pelvis, the calyces, and the collecting system. Then in the 9th week, the urogenital sinus develops into the urinary bladder. And then the bladder is a continuation of the allantois, which later becomes the urachus. So some of these terms are important to understand because of what abnormalities may be seen later on beyond the 9th week. Some of these things do not then develop into their final structures, but remain behind because the embryologic process was interrupted. So that is the importance of understanding these embryologic timelines. And then in the 11th week, the kidneys ascend. So they start in the pelvis and they move up into the flank gutter area, which that's where they should stay for the rest of development and throughout our lives. But knowing that they do ascend is important because sometimes some don't, and a pelvic kidney may remain in the pelvis. So we call that either a pelvic kidney or a displaced kidney. So understanding those things is just a little bit of a review from embryology, just really basic embryologic understanding of the urinary system. And then also knowing that at the end of that first trimester is when those kidneys start to produce urine. And again, urine is what is the amniotic fluid. So knowing that's where that amniotic fluid is being sent or coming from. All right, when we're evaluating the kidneys on our obstetric patients or our fetuses, they can be seen as early as 12 weeks, which is pretty amazing. Usually that's going to be on your really thin patients, or possibly seen transvaginally if you happen to be doing a transvaginal evaluation. They are going to be a little bit more hyperechoic with a more anechoic area in the center of the kidney. And then in the 2nd trimester is when we actually want to identify the kidneys for sure and determine if they're functioning properly. So they should be isoechoic to hypoechoic structures. If you have trouble identifying the kidneys, this is where you may need to play with your ultrasound machine a little bit. I always like to use adjusting the dynamic range. It'll make the image look a little bit more grainy or contrasty, but that can help make those kidneys pop. Some people also like to change the gray maps or tints. Some people like that kind of gold or sepia tint. Some people like that blue tint. Just kind of a fun fact, the human eye can see the most shades of the color blue. So if you are struggling with something, try maybe a blue tint map, and that can be really helpful in things like this. So when we're evaluating the kidneys, we want to see what is the number of kidneys. Are there 2? Is there 1? Is there none? Is there 3? So making sure you're looking for the number of kidneys. Is that shape what we would expect of a kidney? Is the size of the kidney normal? So kidney length should correlate in millimeters by gestational age. So a 27 millimeter length kidney should be about a 27-week fetus. If they're smaller or larger, why is that? What's going on? Is that echogenicity isoechoic to hypoechoic like we expect? And then what's going on with the renal pelvis? Can you identify the renal pelvis? If you can, is it within that normal range or is it dilated? And and then the reference ranges depend on gestational age. So if we're less than 28 weeks, it should be 4 millimeters or less in dilation to be normal. And then if we're greater than 28 weeks, it would be 7 millimeters or less. Anything above those with their respective gestational age would be considered dilated renal pelvis or even hydronephrosis, which we'll talk about later in this lecture. And then if you do see dilation, is the ureter involved? If it's greater than 2 millimeters, that would be considered dilated, and then you would want to follow that as well to the bladder. Is the bladder dilated? Is there an obstruction there? So just looking at all those normal things, similar evaluation to the pediatric or adult kidney, but just on a little baby fetus. So on ultrasound here, we can see some examples of a kidneys evaluation. So here's a left kidney on a fetus that's labeled left. They actually measured the length and the anterior posterior dimension. The length is 3.04 centimeters or 30 millimeters. So this fetus I would expect to be about 30 weeks gestation. And then looking in the transverse view, we can see a kidney on the left side here, and then a kidney over here, and they actually measured these renal pelvises. I don't have a measurement associated with this image, but I would wager that that is normal. So sometimes you can see those renal pelvises and they look a little bit prominent, but it can be a normal amount of fluid. So you always want to throw a caliper on there. And you can put calipers on these in a normal patient to prove that it's normal. You don't need to put any numbers on the report, but you might want to just give the interpreting physician information to determine if it is normal or not. Then we want to evaluate the bladder. Again, the bladder can be seen as early as 12 weeks. That's when urine is being created by the kidneys, so that makes sense. And then we want to detect if there is the 3-vessel cord, the 2 umbilical arteries that wrap around the bladder. Is the bladder present? Is it absent? And then is it normal appearance and size, or is it large or small? So one thing to note about the bladder is it does empty about every 30 minutes to 45 minutes. So if you notice that there isn't a bladder, for example, initially, wait and reassess that later on in the exam. It may fill up over time, or if it's really dilated, again, wait and assess. Does it stay really enlarged or dilated, that bladder, during the exam, or does the fetus urinate and then it goes down to a more normal size? This is all going to help you communicate to the interpreting physician if that bladder is functioning normally. And if the bladder is appearing more dilated, what's going on aside from the bladder? Is there polyhydramnios? Is there oligohydramnios? Is there fluid backing up into the kidneys? That's all information that can be helpful to seeing the big picture. So here we talk about amniotic fluid assessment, which is an indirect assessment of the bladder, because if it is normal, we make the assumption, I should say indirect assessment of the bladder and kidneys, not just the bladder. If the amniotic fluid is normal, then we have to assume that there's at least one kidney working and that the bladder is able to empty. If we are seeing oligohydramnios, we want to see what is causing that. Are the kidneys not functioning? Is there a blockage of allowing that bladder to empty? What's causing that? And then ultimately, if we see oligohydramnios, it can then result in pulmonary hypoplasia, which can affect the fetus's ability to breathe as a neonate. And then we also can identify fetal gender or sex as being used more commonly, not gender, because we don't want to assign a gender to a fetus. But we do talk about anatomic sex presentation. On ultrasound, here again we can identify those kidneys in the transverse view, adjusting that dynamic range if needed. And then identifying that bladder is within the pelvis and is about the size that we would expect. And then evaluating that 3-vessel cord, the umbilical arteries are on either side. If you note just one umbilical artery, you would call that a 2-vessel cord. And then you would want to confirm that looking at the cord in transverse as well. And then for gender or sex, we use the female identification of the 3 lines. People call it like the hamburger sign, so we see 3 bright white lines here. And then the turtle sign, we would see the scrotum and the penis in the shape kind of a turtle. Usually you do need the fetus to be cooperative and have the legs separated enough to see these things. If you don't see a penis, you can sometimes, the scrotum can look a little bit like the hamburger sign, especially if those legs are really pushed together. So don't tell patients or confirm the sex of the fetus unless you've seen it 3 times for sure well. So look at it, go look at something else, look at the bladder, look at the kidneys, come back, look at it, measure your femur, come back, look at it at the end, and then do your confirmation. And if you are not sure, just tell them I'm not sure, get a second opinion, just don't share. If things don't look normal, that's also a time to get a second opinion, and we'll talk about what those things look like later on. All right, so getting into some abnormal things. So Potter's classification is renal cystic diseases. So we're going to talk about those different appearances. So there is type 1, also called infantile polycystic kidney or autosomal recessive polycystic kidney disease. You'll see these terms. Some of them are not used anymore, but I'm just sharing all of them with you depending on what you end up seeing in the clinical setting and in your testing world life, whether it be my exams as well as board exams. So just know both. So this is where we'll see enlarged kidneys bilaterally. There isn't a measurement on here, but you can tell that this kidney takes up quite a bit of space in the pelvis, or in the flank, excuse me. They're going to be increased in echogenicity, a little bit brighter than we would expect, and we don't see corticomedullary differentiation very well. And then because this impacts the function of the kidneys, the bladder may be smaller, absent, and then ultimately the fetus may not produce urine and result in oligohydramnios. This autosomal recessive congenital cystic disease, kidney disease, is associated with Meckel-Gruber syndrome, which is occipital encephalocele polydactyly, and then kidney disease. Here is a little video clip demonstrating these very enlarged kidneys seen in the fetus. Here they are, and they are very bright. Let that run through one more time. Here they are. So you would want to throw measurements on that as well. Right, then there's type 2 multicystic dysplastic kidney disease. You've maybe heard of this in your abdomen course. These cysts are large typically, but can vary in size throughout the kidney. It's not super common, but it is the most common form of renal cystic disease that is seen in infants and neonates. So it's a little more common in this population of scanning. Patients with this, or fetuses with this, will have typically one enlarged kidney with multiple cysts seen, and then a normal bladder and normal amniotic fluid. If it happens to be bilateral, you would then see enlarged kidney with multiple cysts bilaterally, and then both kidneys are not functioning normally, and you may see an absent bladder or a non-functioning bladder and oligohydramnios. The example here is just a unilateral demonstration of multiple cysts on that right kidney. It is enlarged. These cysts are varying sizes. This was a 28-week fetus, but you can see that the length of this kidney is 43 millimeters. So very enlarged in comparison to what we would normally expect. We do see a normal bladder, so that other kidney, which isn't pictured in this image, is functioning normally. Type 3 is adult polycystic kidney disease, and this is autosomal dominant cystic dilation of the nephrons. This is seen bilaterally, and this actually does not have any impact on renal function in the fetal life, and usually presents more in adulthood. So typically, if this is something that we're looking for, it's because there's some family history. So incidence is 1 in 3,000 births. On ultrasound, we may see normal kidneys and really is not detectable in the fetal life. However, if it is something that we identify, the kidneys may appear a little bit more echogenic or enlarged. The bladder will be present since it does not impact renal function, and we should see normal amniotic fluid. And then type 4 is obstructive cystic dysplasia. So this is where we have dysplasia of the kidney or both kidneys due to obstructive cystic causes. So ultimately the kidney stops functioning, and then the kidney is replaced by cysts due to fibrosis. This is where renal insult occurs really early in the first or early second trimester and can be really impactful on the development of this child. So it can be caused by urodocele, UPJ or UVJ obstruction, as well as a bladder obstruction. We may see hydronephrosis if we catch it early, and then the kidneys ultimately result in being echogenic, and then oligohydramnios can result. So this is an example of that obstructive cystic dysplasia seen really early in a young fetus, and we're starting to notice some decrease in amniotic fluid. So this is not probably a good outcome for this fetus. All right, so I'm just going to throw in there, if you are watching this, you need to email me your, I'm going to assign some things to confirm that you have watched this video. Please do not share with your classmates that this is a requirement. This is for me to check in and make sure that everybody is taking time to watch the entire video. So Kylie, I would like you to email me an email with the subject line, my favorite, and yours is going to be fruit, and then in the body of the email you can tell me what that is. Natalie, you'll do the same thing but for vegetable, so subject, my favorite vegetable, and then in the email your answer to that. Mia, yours is your favorite dessert. Maddie, yours is your favorite animal. Erica, I'd love to know your favorite song. And then Emily, what's your favorite movie? So please take time after you've completed watching this entire presentation to email me those things, and then I know that you are engaged and taking time to watch these. All right, so we're going to move on to obstructive urinary tract anomalies. Just remember, obstructions can occur anywhere along that urinary tract. So wherever the obstruction occurs, then you need to follow it back up. So the further down, the dilation will occur throughout potentially the system or up, or if it's just right at the kidney, you may see urine collect there. So starting with pylectasis, this is the dilation of the renal pelvis without extension into the renal parenchyma. So this is usually the first area that the kidney dilation occurs. It can be unilateral or bilateral, and it is associated with a couple things. So trisomy 21 is one. It's actually a soft marker for that. And then ureteral vesicle reflux is the more common thing. So that is where there is some prevention of those, actually not prevention, but there are valves that prevent urine to flow back into the ureters from the bladder. But if those valves are displaced or not working appropriately, then when the bladder squeezes, urine backs up into the ureters and can go back into the kidneys. This is not associated with congenital abnormalities, but can really impact that baby after it's born. It can cause kidney infection. So when baby is in mom, it's really not that big a deal. It's a sterile environment. They're swallowing urine, things like that. Not a big deal. However, when it happens after baby's born, that's when if that urine's going back from the bladder into the ureters, since that bladder is now exposed to the outside world, infection can creep up and go into the kidneys and cause a lot of issues, as well as back up over time can cause some damage to the kidneys. So these fetuses are going to have a pediatric GU consult, because they may need to have, for sure, surveillance after birth about their renal function, but potentially even surgery as a little baby or young toddler to resolve that reflux. So interesting situation, commonly consulted, commonly seen, and is more likely in boys. Okay, that's not on the slide, but something to note. If you see dilated renal pelvis, you want to label the right and left correctly. So this is a time when you will want to always know your fetuses right and left. And this is why I emphasize in OB2, and I hope that you have learned clinically as well, why it is important to always know the baby's the right side and the baby's left side, because when you come across something, you automatically know, oh, this is the baby's right kidney. I know that. Because if this patient is going to be then followed by GU surgery, they want to know which side has been struggling to drain in utero, and is it consistently persisting after birth, and the one that needs surgery. So always know the baby's right and left, and it's dependent on your baby's position where that is. All right, hydronephrosis. So this is going to be where the kidney then is retaining urine due to some obstruction. So the urine is now backing up, not just into the ureter, but the renal pelvis, but into the kidney. Again, this is more common in males, and this can extend into the renal parenchyma, and this also is the most common fetal anomaly that exists. Out of all of the things we are learning this summer, it is the most common thing. You will see this if you're scanning OB. You probably also will see this when you are at clinical, and it will be kind of like, oh, another one of those. But it's so important to identify and label and document which is right versus left. This can be seen unilaterally or bilaterally. It can kind of ebb and flow. It can get better and worse, but we're still going to track it over time. And this is also associated with that uretropelvic reflux, as well as bladder outlet obstruction. So using those reference ranges that we talked about in second semester for normal is important to reference. So if we're before that 28th week gestation, we want to remain below 4 millimeters to be considered normal. Anything above that would be abnormal. And then evaluation after 28 weeks would be anything above 7 millimeters dilation would be considered abnormal. So here's a couple examples of hydronephrosis. Here we can see that renal pelvis is dilated, and then we can see dilation into that kidney. This is bilateral dilation, so then we would want to look at the ureters and bladder, and this bladder looks pretty big, so probably a bladder outlet obstruction. Not seeing a ton of fluid around the baby either, so concerning for oligo. And then here's another example of what that can look like differently, where we have really large renal obstruction and hydronephrosis demonstrated here. When it gets to be like this is going to be more concerning in how that renal function is going to be. That renal tissue is getting really pushed out and stretched, and that can impact renal function. Ureteral obstruction, you learned about this in your abdominal class. So this can be caused by a couple different things. So the ureters are a tube, so as they progress from the kidney to the bladder, you would think that they would be straight, but sometimes they kind of kink and bend, so that can cause obstruction within the ureter. They can also be obstructed due to the valve placement at the bladder. So depending on where the obstruction is located, it can be called a uretopelvic junction obstruction, so that renal pelvis is dilated, or it can be at the level of the bladder, where it's uretovesical, and that would be demonstrated with uretal and renal pelvis dilation if that is the location. Then if we see obstruction be further down the line at the level of the bladder, then we would call that a bladder outlet obstruction. So this would be where we see an obstruction at the level of the urethra. We would see urine backing up into the bladder, both ureters and both kidneys, and again, this is more common in males. We would see bilateral hydronephrosis, dilation of the ureters, and then posterior urethral valve obstruction. And that causes bladder dilation and resembles a keyhole appearance. So keyhole, like a very old key, in very old, like Victorian style. The key is bigger on the top, and then there's a little bit smaller appearance on the bottom. And then because we don't have any urine exiting into the amniotic space, then we have oligohydramnios. All right, and then we have some images here. So this is that keyhole appearance. You can see that bladder is very, very dilated. Here is that urethra. The obstruction is right here. Because of that dilation and obstruction, there is no or anhydramnios as opposed to oligohydramnios. So this poor baby is not going to have very good lung development. Here is an example showing bilateral pylectasis or hydronephrosis, as well as an enlarged bladder. So two different examples there. Another thing that can be seen is something called a urinoma. This is where we would see a cyst, and usually it is adjacent to the spine and kidney. It does contain urine, but it doesn't communicate with the kidney, and this is caused by some type of urinary obstruction. It may, on first glance, look like ascites, but you can see that it's encapsulated into one side of the fetus. Here's an example of a urinoma with a cine clip. So we do also see some hydronephrosis on that side, as well as that urine collection there. So it is next to the spine and the kidney, and that's a big, large urine collection, a urinoma. That can be seen in a male or a female fetus. Duplicated collecting system. So this is where we have two collecting systems that develop. It can be a single kidney that has like a bridge or a connection, but it has two dual collecting systems. The collecting systems do not communicate with each other, but they do sometimes connect to a common ureter, or sometimes they have two ureters. This is the most common renal anomaly that is seen, and sometimes this isn't detected unless it's abnormal and may not be seen until a patient is an older pediatric patient or an adult, but can be seen in utero in the setting of abnormality. So here we actually see dilation of both of those collecting systems on that one side. Then we can have a uretocele. This is where we have cystic dilation of the ureter at the distal location. This is associated with that duplicated collecting system. So if you see a duplicated collecting system, you would want to look for that uretocele, or if you saw a uretocele, you would want to go up and look for a duplicated collecting system. But they don't always go hand in hand, but can. This is caused by ectopic insertion of the ureter into the bladder, and then causes a little bit of obstruction in that location. So here is that urinary bladder, and then that ureter is displaced there and can cause that obstruction. So the cause of this is can be congenital or may be acquired over time, but it is because of that ectopic placement there. So on ultrasound, you would see an anechoic cystic mass or area adjacent or near that upper pole of the bladder. Prune belly syndrome is a complex malformation with 3 features. We will see an anterior abdominal wall, so the front of the abdomen is distended. Some type of urinary tract obstruction that is causing that distension, and then cryptorchidism. So another thing I want you to look up and tell me in that same email is defining what cryptorchidism is in your own words. So look it up and then define that. So now you have 2 things to email me to prove that you watched this video. What we are looking at here is there is some embryologic defect that causes some urethral obstruction. And because of that, that entire collecting system is distended. So there is the bladder's enlarged, the urethra is enlarged, and that can go into the ureters and kidneys as well. And so then what happens is that distension causes those abdominal wall muscles to really stretch, and then ultimately they just become hypoplastic and don't develop. So the abdomen is super stretched and those muscles aren't keeping the abdomen in. And then when the baby is born, and urine is released, the abdomen shrinks up and looks kind of like a raisin or a prune because those muscles never were developed to create that tone and tightness in the abdomen. So on ultrasound, we will see a large anechoic bladder. We'll see hydronephrosis due to that, both of those caused by that obstruction, and then that results in that distended abdomen. The thorax is going to look small in comparison, and usually the lungs don't develop, so we have pulmonary hypoplasia, and then oligohydramnios, which is causing that pulmonary hypoplasia. So kind of a sad outcome for these kiddos. All right, moving on to the next topic, which is congenital malformation of that urinary tract. Renal agenesis is one of those things that can happen. This is where we have absence of a kidney or both kidneys due to failure of the uretic buds not developing. This is associated with maternal factors, diabetes. We talk about diabetes a lot, and then also cocaine use in pregnancy. So unilateral occurs more commonly than bilateral. Again, this is more common in males for bilateral, but equally common in males and females for unilateral. So on ultrasound, if you had a unilateral appearance, you would see normal bladder, normal amniotic fluid, but only the presence of 1 kidney. So if you don't see the kidney in that flank area, make sure to go look in the pelvis, but usually you would just see the 1 kidney. Then bilateral renal agenesis is less common. It's more rare, more common in males, though, if it does occur, and is lethal, unfortunate outcome for these fetuses. So since there is no urine production, this results in oligohydramnios, and then that causes pulmonary hypoplasia because there isn't enough amniotic fluid to get those lungs to develop. And then also because there is no amniotic fluid, it can cause other deformities because there isn't enough space for the baby to develop. So facial anomalies or arm and limb deformities as well. So on ultrasound, you may have normal fluid in that first trimester, but then into the second trimester, when the kidneys start to take over fluid production, we see oligohydramnios or anhydramnios if there is no measurable fluid. We would not see kidneys, and nor would we see a bladder because there is no urine production, and then that's due to the kidneys not forming. We do see adrenal glands, which can mimic the appearance of kidneys, so we'll talk about what that looks like. So you don't want to mistake an adrenal gland for a functioning kidney, and we use that color Doppler to demonstrate that. So here is an example of unilateral. So in the transverse view, you'll see that kidney on one side. On the other side, or absent kidney. And then the kidney that is present may be enlarged or bigger than we normally see because it's doing the work of two kidneys, basically. It's filtering all the blood for the whole body through one kidney. We'll see a normal bladder. We'll see a normal amniotic fluid. We may see a single renal artery, or we will see a single renal artery coming off of the aorta. So here we can see that in long, and if we turned color on, we would see that banana peel only on one side. We wouldn't see it on the other. Here is a cine clip demonstrating the absence of that kidney on one side, but the presence of that kidney on the other. So it looks like it's on the right, but we're seeing no kidney there, but you see this kind of hypoechoic area, and that's that adrenal gland, and it's lying down. So normally the adrenal glands sit on top of the kidney, but here we can see that kind of falls going up and down. Let that run one more time. So normal kidney there on the right side, going through the spine midline, coming over to the left side, and absent left kidney there. Bilateral renal agenesis has a little bit different appearance. When we're looking for the kidneys, we do not see kidneys bilaterally. And then if we look in long or sagittal, here are actually those adrenal glands. So again, those adrenal glands should sit on top of the kidney, so they would look like this. But if the kidney's not there, they kind of fall and have this kind of laying down sign is what it's called. It can look like a small kidney, but that is not what they are. They are the adrenal glands. And then if we turn color on, we don't see any blood flow coming and directly going into those adrenal glands because they do not have the renal arteries connected to them. So again, looking for the renal tissue, absent renal tissue, we do see adrenal glands. Using color Doppler to prove that we have absence of those renal arteries. We'll also see oligo, absence of fluid or anhydramnios, and then an absent bladder. And this is again bilateral renal agenesis. Here is a video clip. So note the first thing that you would notice is no fluid around this baby. And then scanning transversely, looking for the kidneys on either side of the spine there. Get that to run one more time. So we see no kidneys there. You can see those adrenal glands, but they are very small with no kidneys. And then absence of a bladder as well. Right, then there's something called Potter sequence. So this is just an acronym that is bilateral renal agenesis, and it's progression over time. So what is seen is just kind of helps you remember what's going on with bilateral renal agenesis. So we have the absence of both kidneys, which causes oligohydramnios, which then causes pulmonary hypoplasia, twisted skin, twisted face, flattening of the face, chin, ears, and can cause extremity defects. So a sequence is a pattern of multiple abnormalities that results from a single primary anomaly, which in this case is renal agenesis, and it could be a malformation as well, and then it causes other things to happen down the line. So Potter sequence, we have oligo that's caused, that causes facial deformities, but oligo is caused by that renal agenesis bilaterally. So not to be confused with Potter's classification of renal cystic disease, this is Potter's sequence. All right, another malformation is a horseshoe kidney. So this is where we can have a fusion of both kidneys at the typically inferior pole. So you would see that kidney kind of bridging at the midline. This does occur in 1 to 4 births of 1,000 patients, and this is more common in males. So on ultrasound, what we would see is that connecting isthmus or bridge between the right and left kidneys. Usually it's on that lower pole and can have a more curved appearance, or the lower pole is elongated, and if you follow it, it connects to the other side. Here is a video clip showing those kidneys. So that's going from inferior where they're connected there, moving superiorly, stomach and chest where they are not connected. Connected there. And let that run one more time. And then you would want to throw some calipers on those renal pelvises to see if they're normal or not. Renal ectopia is one or both of the kidneys are outside of that flank or normal position. On ultrasound, these kidneys can be a little bit smaller than normal or rotated in that displaced location. Usually they're a little bit superior to the bladder or adjacent to that iliac crest. So if you don't see a kidney in that typical renal fossa location, you want to go down towards the bladder pelvis area. So here we see a bladder and then a kidney just adjacent to it. So this is a 23-week fetus where there was no kidney identified in the left renal fossa, and then they moved into the pelvis and noticed that left kidney was in that pelvic area. Here is a cine clip showing the bladder here and kidney tissue there. I believe we saw normal kidney tissue up here. Normal kidney there. Absent kidney here, and then kind of a bit lower. So checking all of the areas that kidney would be located. Moving into bladder abnormalities, there's exstrophy of the bladder. So this is protrusion of the bladder wall outside of the body. So this is where the trigone and ureteral openings are. This occurs to a defect in the anterior abdominal wall during that 4th week of development. So on ultrasound, what you'll see is an irregular kind of mass-like shape below the umbilical cord, but outside of the abdominal wall, so kind of abnormal like pelvic mass outside the abdomen. And you'll see kind of absence of the bladder, but the bladder is there, it's just not located in the normal location. But you don't see a normal bladder urine reservoir in the pelvis. But you notice normal fluid. So then you know that the kidneys are functioning and urine is getting out into the amniotic fluid, but it's just not being retained in that bladder reservoir in the pelvis. So then you want to look for a mass. So we can see that in 2D here. And then this actually shows really well that umbilical arteries or 3-vessel cord is there, but it's just not retained within that pelvis. It's outside of the abdominal cavity. Right, and other things we can see is urachal anomalies. So this is where that lumen of the allantolis persists, and then the urachus is forming, and a fistula develops, causing urine to flow from the bladder to the umbilicus and result in urachal cysts. So there can be different levels of this. So the urachus is where urine would have emptied until the entire urinary system formed. So we can see cystic structures or complete patency of the urachus. So you'll notice urine collecting in the bladder potentially, and then even in the ureters, but then you may also see this more anterior projection of the bladder towards the umbilical cord location, and that would be a patent urachus. You may also just see a cystic structure in that bladder area, It really kind of depends on what happens. So just know that's more of an anterior cystic or tubular appearance, because the bladder drains through that urachus and allantois out through the umbilical cord in that early embryologic life, and that will eventually go away, and then the urine drains into the ureter. But if that doesn't go away, it would be considered a persistent urachus, and then fluid can collect, or urine can collect in there. Sometimes the whole thing doesn't persist and it's more just a cystic area. If the whole thing persists, then it would be a patent urachus, so like a different separate tube. All right, mesoblastic nephroma. This is a solid tumor of the renal tissue. It can have cystic components with it. So this is the most common fetal renal tumor that occurs, although it is rare. It is going to be more common in males. So what happens is we have benign hamartomatosis, congenital renal tumor, and this is can be malignant as well. But on ultrasound, what we see is an echogenic mass. That kidney can look large because of the mass. It'll have increased vascularity. It will actually grow pretty rapidly over time, and this one can cause poly. So you've been hearing oligo, oligo, oligo all throughout this lecture, but this one is associated with poly, so this one is unique. And then because of what it does, it can cause hydrops as well in the baby. So this is an example of a 32-week fetus that had an enlargement of the right kidney, but what actually was going on is there was a mesoblastic nephroma of the kidney. So we would turn on color, see if we can define that mass. They also noticed poly on this baby, so a couple different things concerning. Sometimes things like this might actually need like an MRI to get a little bit further detail. But you want to put all those pieces together for the clinician. Excuse me. Neuroblastoma is actually an adrenal tumor, but is common enough that we'll talk about it in this section. So that's an adrenal tumor with cystic and solid components. It is near the kidney, but is located within the adrenal gland, and should be encapsulated and distinguished from that kidney. You may hear this called a Wilms tumor, and this is the most frequent tumor of infants in childhood, and it accounts for 8 to 10% of childhood cancers. It does show up pretty early in life. These kiddos can have elevated catecholamine levels, and in pregnancy, moms may have preeclampsia or hypertension associated with this neuroblastoma. Again, this is the most common tumor of childhood. It is associated with a couple of different syndromes or diseases: Beckwith-Wiedemann, Hirschsprung's, DeGeorge, and neurofibromatosis. On ultrasound, what you'll notice is a tumor that is usually echogenic or homogeneous in appearance to the kidney, that is adjacent to the kidney, usually should be superior, or may like displace that kidney depending on the size inferiorly. Sometimes it can be a little bit more lateral to the kidney though. Typically they're going to be hyperechoic, but they can be homogeneous as well. And then the larger tumors can have a more complex appearance. Sometimes these aren't seen until the 3rd trimester, so if a baby doesn't have anything other abnormalities going on, this could be missed, unfortunately. And then this is also associated with poly. So here we can see an echogenic mass, just a little bit superior to that renal fossa, and then if we turn color on, it doesn't really have as much echogenic or vascularity as some things can. All right, cyanomelia, we mentioned this in a previous section in CNS abnormalities. But this is partial or complete fusion of the lower extremities. And the reason this comes in this area is because it is associated with renal agenesis and oligohydramnios, also known as mermaid syndrome. Super rare, more common in males though if it does occur. And what happens is vascular interruption of blood occurred and caused blood to divert away from the caudal development of the embryo, which resulted in absent or abnormal development of those structures. And this is associated with thalidomide, teratogen, so I don't think people are taking that purposely if they are trying to get pregnant right now, but did maybe occur at some point. This is super rare and I have never seen this. So on ultrasound we would see fusion of deformities of the lower extremities. We can see abnormal vertebrae or sacral agenesis, which we talked about in the CNS abnormalities lecture. There can be partial or complete absence of the pelvic bones. And then when it comes to the kidneys, we see bilateral renal agenesis or dysplastic kidneys due to the obstruction of the urine being not able to empty. We can see an absent bladder if we have renal agenesis. There can be an imperforate anus, a single umbilical artery, and then genitalia can be absent or ambiguous. And then there can also be GI and cardiac abnormalities seen with this. So lots of abnormalities, and unfortunate outcome is lethal for this diagnosis. Right, genital abnormalities. So testicular hydrocele can be seen in utero. Maybe you've seen this clinically on children or even adults. So this is accumulation of fluid in the tunica vaginalis due to some communication with the peritoneal cavity. This can be unilateral or bilateral. I would say when I've seen this, typically it's bilateral. And then fluid surrounds the entire testicle. So you can see here are the testicles, the scrotal sac, the testicles within the sac, and then we see fluid from that peritoneal cavity. So the testicles descend into the scrotum through that inguinal canal, and if that canal is still patent, that's when abdominal fluid can go into that tunica vaginalis. Undescended testicles is something that can happen. This is where the testes are still in that inguinal ring. They do remain there until about 28 weeks sometimes. So this is also known as cryptochitism. It's really difficult to confirm or evaluate this in utero, but sometimes can be seen. You may see it more indirectly, noticing that there's no testicular tissue in that scrotal sac. So not something that would always be confirmed because those testicles kind of can move into that sac, kind of move back and forth, and will eventually stay in the scrotal sac later on, even after birth. For our females, ovarian cysts can be seen, so we've talked about that in gyne. So that can usually is caused because of mom's hormones are affecting the fetus. So we would see a cystic area in the abdomen or pelvis area, and these can be very small and unilateral, or kind of large as well, unilateral, or both can be seen bilaterally. You would just want to follow those cysts. Do they communicate with anything, the bladder, GI tract, or anything like that? Are they anterior? Could it be a urachal cyst, or is it connected to the ovary? And then things that can happen is you could technically get ovarian torsion in utero. So unfortunately, not really much we can do on a fetus, but just something to note. Here is an example. So we have that bladder and then this really large cyst. So we can see normal kidneys on this this baby, but that large ovarian cyst. All right, sexual ambiguity. So ambiguous genitalia is where we see external genitalia that we are not able to confirm that it is male or female. Sorry about that typo. So this can have various appearances, and a child can be born with a micropenis or no palpable gonads, and or we can have a male fetus that has a hypospadias with only one palpable gonad. So this is commonly caused by congenital adrenal hyperplasia. Just to be aware of, if that is something they know about, that is a genetic disease that can be detected with genetic testing. So on ultrasound, we may notice the presence or absence of a uterus, as well as also identifying testicular tissue, or we can see so ovarian tissues, tissue, and normal or abnormal female external genitalia as well. So there's kind of a spectrum and variation of how this can appear. And then we can also see enlargement of the kidneys and adrenals as well. So I'm not going to be testing you on any of this. I just really want you to be aware of it. Just if you see it clinically, it is something you do need to make the physician aware of. So ambiguous genitalia, you might see a combination of the 3-line sign and the turtle sign, or they're absent and you can't really identify what's going on. So here it's just like, is that female? Is that male? Is that externally located scrotum? Is it prominent labia? A little bit difficult to identify. Is that a small penis? Is that an enlarged clitoris? So it's just really hard to confirm the sex of the fetus in these cases. Hypospadias, this is the opening of the urethra that is located on the underside of the penis, and on ultrasound it can have a more blunt-ended appearance, or also called the tulip sign for a hypospadias. So normally we see a more rounded end, but here we can see that that uterus has more, or the penis has more of a blunt or flattened shape. And here we can see kind of an abnormal or small appearance of those structures. So this would be something we would want to identify, and this can cause also some urinary issues as well. Then there's true hermaphroditism, where we have intersex tissue presented for both. We can have both ovarian and testicular tissue in a fetus and newborn. We have ambiguous genitalia appearance, and then ultimately later in life we can have some abnormal hormone production where we have amenorrhea in a female or gynecomastia in a male with cryptorchidism. So mostly things to be aware of. These are all after birth pictures. So this is actually scanning the labia of what was assumed to be a female patient, but testicular tissue is noted in the labia. This one, there was some adrenal gland issues, so that's not necessarily genitalia presentation, but associated with hermaphroditism. And then here is a really small uterus on a pediatric patient, so almost unidentifiable. Again, this is not going to be on any tests or anything, but just more so to be aware of, especially if you're going to be working in a pediatric environment. So we can have pseudohermaphroditism, where we have a male that is 46XY, but the gonads and testes, there are gonads and testes, but their secondary sexual characteristics are more female in presentation. And then we have female pseudohermaphroditism, which we do have normal 46XX. There are ovaries, but then there is secondary sexual characteristics that are external that have more male appearance. and that one is caused by congenital adrenal hyperplasia. Something to be aware of, this is a little bit different. This is persistent urogenital sinus. So this is an abnormality of the Müllerian or paramesonephric ducts. This is rare. So what is going on is we have our urogenital sinus that is our embryologic structure. So the urinary system, the urethra, the vagina, and the rectum actually are all one structure. That start is the urogenital sinus, and then as we evolve and develop over our embryologic life, the urethra, vagina, and rectum differentiate into 3 different structures. So if those do not differentiate, we can have a connection between the two. So we may have where the vagina and the urethra are connected and only one. And then you can also have it where the rectum is also part of that same opening. So usually it's only 2 orifices, but I had a patient once that the baby only had 1. So that can be really abnormal looking in appearance in utero, and then can cause some obviously infections and issues with life as well after. So something to be aware of. Not going to be having huge testing on that or anything. So, and then these are my references. So I want to make sure that you go through and took notes during that, and then come to class with at least 1 or 2 questions about what you want to discuss or have go into further during class. And I'm excited to see how this goes. So thank you for taking time to watch this.